Steve has mentioned my colleagues who are listed here on the opening slide. But let's I want to, if you're not familiar with Maine, the area in yellow or off-white, depending on your color vision, this is a USDA map of Maine, and the yellow or off-white areas are rural. So the majority of our state is considered rural, and many of the areas depicted here are unorganized territories or townships. Maine's rural healthcare structural crisis, we're not alone with. Other rural states certainly are facing these issues. Nearly half of our rural hospitals are at risk of closure, and that risk is worsening as we anticipate Medicaid cuts over the next several years. 29 nursing homes have closed in the state, which has made support for aging in place much more imperative than ever, and birthing units to continue to disappear. I think we lost 1 or 2 last year, for example. EMS agencies, Life Flight of Maine, are absorbing the burden as our rural hospitals lose services and the ability to provide a full range of care as maybe they had once. And the other thing that's going on is that traditionally we have tried to get clinicians to work in health professional shortage areas in the state, through incentive programs like tuition reimbursements, et cetera. Those programs over the past 50 years have not solved the problem of insufficient workforce and a willingness of people to live in these rural areas. So expanding facilities, recruiting more staff don't work because we fundamentally have these 3 categories of systemic trouble: collapse of commercial payer mix. We've lost industry with our pulp and paper mills and other employers in the state. And so we don't have commercial insurance as a strong presence in the payer mix in rural areas, and Medicaid reimbursement is inadequate on its own. Fee-for-service models do not work for low-volume rural operations, and escalating workforce costs. Rural organizations can't compete with the salaries, for example, that are offered by employers in more urban areas. And we have inefficient aging infrastructure that cannot be replaced. There is insufficient funding to replace that. In response to these problems, and to not continue to pursue what are futile measures to try to sustain care, we've turned in our work here in Maine to AkeLex, HealthSaaS, and Pocket RN have developed an approach to. It's not simply a technological solution. It is a technologically enabled approach to distributed primary care in the context of home and community, and it links with community paramedicine, patient navigators, and I'll describe that in a little more detail here. So it's both a social and a technical innovation in that we have technology, ontological AI developed by Steve Datena's company, AkeLex, and agentic workflow. Pocket RN provides 24/7 virtual nursing triage. Remote patient monitoring technologies are provided through HealthSaaS. There's device-based medication adherence. Patients have digital care journals. There are telenavigators and virtual care teams, as well as navigators in the context of community. And importantly, a very core capability to make this work for standalone primary care is advanced community paramedicine, which Jonnathan Busko has been instrumental in developing and implementing programs in communities in Maine for community paramedicine. There's an overarching goal here of moving from emergency response to risk reduction in the community. Instead of people becoming critically ill, they're living 2 hours 3 hours away from a hospital. They may or may not have primary care access. Their chronic condition can worsen until they end up in crisis, and then EMS is called to try to get them to an emergency department. We're trying to provide primary care in the context of the home with these technologies and these approaches to avoid crisis, to keep people well in the context of home. And in doing that, the safety in the context of home really requires that social determinants of health, understanding the whole person's life in the context of where they live, is important. It's part of the community paramedicine and patient navigator approach to understanding concerns or requirements that are specific to a person's life. This approach is designed for sustainability. The technology extends the reach and skills of existing workforce. It does not demand additional workforce. It also provides a pipeline, an education and training pipeline for people who want to continue to live in their communities as navigators, as paramedics. The technology also reduces administrative burden through automatic documentation. And there are some other features of the technology that reduce cognitive burden, which is Steve Datena may be able to speak to. Clinicians can manage significantly larger panels safely with the technology that we're proposing putting in place. We have had, by the way, pilot implementations of earlier versions of CarePath in Maine, and the CarePath program has also been implemented for aging in place in Washington State, again in earlier versions, with capabilities having been expanded at this point. Recurring revenue, one of the problems with sustaining rural healthcare is that there hasn't been a financial model that works, as described earlier. There is a potential for recurring revenue with the CarePath approach, which is built on remote patient monitoring and chronic care management. There's also automated documentation and population health analytics to support alternative payment models. And ultimately, the program is designed to be financially viable with low volume rural patient care, which reduces the dependence on fee-for-service, which simply, as we've said earlier, does not work in rural areas. Finally, there's so much to this program that I'm glad that our technological support is on the call with us here, and I'm hoping we can get some questions directed regarding the actual functioning of the model on the ground. But I wanted to mention that one of our intentions is to bring safety systems engineering to bear in CarePath to assure alignment of CarePath operations with the system theoretic accident model and processes developed by MIT. This is a safety engineering framework to build and monitor, continuously improve the control structures that we lack in rural health systems, and I think lack in health systems writ large very often as well. There are constraints built into CarePath. For example, if a CHF patient gains 3 pounds overnight, the agentic AI is making note of that, is communicating that to nursing triage, and there will be outreach to the patient. There will be determination of how to respond to that, whether something is going on that warrants emergency transport or whether a community paramedicine visit will be coordinated. The bottom line there is that there's a constraint that is going to trigger action so that person does not languish with worsening illness. And so we've reviewed CarePath with the system theoretic accident model and processes in mind. And I think that we have a lot of alignment, but that's something that we would like to actually explore in more detail. The learning loops are built in. Deterministic AI uses clinical intelligence to support accuracy of treatment and response, diagnosis, and treatment, and support continuous system learning. We're also building a reflective practice component to this. That is our intention at this point. And finally, the National Academy of Medicine report on high-quality primary care. This primary care system aligns with the goals of that closely. I'll stop at this point and see if there are. Steve, how would you like to approach questions or getting some discussion going on this? That was a very brief, shallow dive into what's happening here, and we would welcome some questions that allowed us to deepen.
Great, thank you, Jeff, and thanks for kind of setting the stage here. I'm going to just kind of pick up where you kind of left off, and then I'll ask our panelists, to chime in as well and add to the conversation here as you feel like you want to lead it from where we go from here. But one of the areas you talked about right at the end, it really helped framing is in a kind of a system safety, taking a system safety system safety stance there, Jeff, was that, I picked up right away in my notes, that there are losses that you're eager to avoid, or we're all looking to avoid losses. And those here, you've kind of captured many. There's financial losses that are occurring that we want to prevent, avoid, mitigate, manage. Loss of access was sounds like another goal is to deal with that, and again, mitigate that loss. Also, loss of resources potentially around, especially from the workforce side, or services in general. We know that whole service lines maybe aren't even, may not be able to be offered outside of primary care. Something like, obstetrics or other services that can no longer be sustainable. And you talked about the volume, and then finally, the thing we're always so critically focused on in patient safety, which is loss of life, and how this new approach or our model of care might in fact help us to avoid loss of life. So I thought you brought up a lot of those topics. So model speak to those goals and efforts as well.
I'm happy to jump in on that. I and respond to 911 calls, and as you can tell, most of Maine is rural, so do a lot of rural EMS. I'm primarily employed by St. Joseph Healthcare, but I'm also the senior medical advisor for rural workforce development and workforce innovation for Community Care Partnership in Maine, which is the largest accountable care organization in the state. And my role, and this is implied in a lot of what Jeff says, and Steve, to your comments on the coordination, force to the maximum levels they can safely function. That's where the EMS component has been so important. So one of our first projects was to create a pilot advanced practice paramedic who could facilitate telehealth visits and perform urgent care skills in a rural community, including suturing and removing fish hooks, taking off ticks, looking in kids' ears at 11 at night. And in that project, we reduced utilization, emergency department utilization over 2.5 years, 165 avoided visits, 20,000 driven miles avoided. Because that is a big safety piece in a rural community. If you don't have easy access, you're going to delay care. That was also the site where we implemented one of the early care path demonstration projects. And Frank can certainly give more information on that. But the key to doing that in the rural area was the incredible communication. I 30,000 around here. We have the primary care patients are separated amongst three major groups. we have 3 non-communicating EHRs. When my wife, who's a family medicine doc, gets a report on one of her patients I see in my ED, she gets a 27-page fax, of which 2 pages is my note, and the rest is she doesn't even look at those. She hopes that eventually the note shows up in the state health information exchange, and she can pull it down. So we knew that communication and coordination of services was critical. That's where the AI and Pocket RN fell into CarePath when we implemented a community paramedicine project that was community paramedicine supported advanced RPM model in that same rural community, Jack in Maine. And Frank, actually, that's probably a good time for you to just talk a little bit about that, because I think that really exemplifies what we're talking about, creating safety, communication, and coordination of services.
Thanks, Jonathan. I'm going to share a slide. So just a high-level overview slide of how this works, I think will be helpful to set the conversation going forward. And it's pretty simple in how this works, right? Where patients have what we call device kits. They have a set of devices, blood pressure cuff, scale, pulse ox, device. We talked about device-based medication. Really, the best person to speak to, the previous project we did in Maine is Sam Thomas from Pocket RN. It was his group that did they were and potential escalation to EMS, community-based paramedicine, et cetera. So, Sam, you want to speak to this a bit? Sam on the phone. Oh, Sam. Excuse me, Steve, you want to take this?
Sure. Okay. Frank's talking about, and what Jeff alluded to, is this is not a single solution to a large problem. This is a series of technologies and methodologies to make incentives to stage possible and intervene resources. Also communicate throughout the entire clinical stack, get the right information to the right person at the right time. And so what we've been working on is really about, once the system identifies a problem, how do we distribute that information throughout the network of clinical providers are available. Some of those need to go to virtual nursing. Some can go to health navigators we're talking about. Some of them need to be escalated to a paramedic or even go into the primary care clinic. So a lot of what we're trying to do from facilitating, I think the single most important thing we're doing about facilitating communication with the existing primary care networks is to keep the knucklehead stuff off their desk in the first place. So a lot of happens external to the existing primary care network, and then that has been condensed and optimized to communicate whatever it is, the information that they need to know. So again, it's just in time. It's kind of like thinking about it from an industrial standpoint. It's a lot about just in time management, getting the right information. So I'll stop there.
Like we know that from a patient safety perspective that, there's lots of data that supports that that communication still remains kind of one of our primary root causes, maybe up to 70%, some say 80% of as sort of our adverse events and sort of the loss of information. And that's another loss that I know you all are thinking about avoiding. And this seems to be a way to kind of think about how we're going to get the information, the right information to the right patient. So yeah, this approach, you know, and thinking about this in how this is being done in a rural area, to the group about, you know, geography, and you talked about a little bit more about the environment itself. I wonder if there were any kind of, from the folks that were involved in the changing care model here, if there was this a more of a push or a pull, you know, to make this change? And then also maybe along with that would be maybe a discussion about the unique tailoring of the technology and the staff. If we're talking the either the local workforce or and also the patient population, the you know diverse population that you have in rural health as well. I don't know who wants to. Just thinking of some of the unique barriers.
I think that's a great query, Steve. I think Jonnathan, Charlie would be good respondents for that.
You want to pose that again, Jeff, or Jonathan, or Steve, rather?
Yeah, Charlie, I think just the unique, you know, the unique challenges that you faced in this changing care model with either rural workforce, the community itself, or the patients at large in the rural settings. For adoption, for change, maybe for acceptance, you know, all of those things is successful. And what we're all trying to do safely and effectively.
Well, I think the introduction of new ideas into a complex adaptive system, which is certainly what we're dealing with, is fraught with with concerns. Not all the agents in that system are likely to agree that this is a good idea, and so and I certainly went through this in my own practice back in the early 2000s. That the whole idea of focusing on skills-based training, I think we may see some resistance from some of the professional organizations. So I think that there.
And I just to jump on that, just specific to the original Jackman program that we put in place using physician extension with the advanced practice paramedics, we knew where there would be some regulatory pushback. We used a tool called informed community self-determination to work with that's a program where it's tax. So the taxpayers in that community voted to increase their taxes by 30% because their mill rate was really low, to have that system of services available. And I think you bring up a really key point that often gets missed, that in this work, this patient and this is the benefit that they'll get. I think that, and this is particularly easy in some ways in rural communities because you're dealing with smaller populations. Your sample sizes are half the population will show up if you've got food and an open mic for them to express their opinion. At least they're also going to play a tremendous part in the safety aspect, because ultimately we can build all these agentic systems that we want that are continuously monitoring, but if patients won't engage with them because they either don't trust them or they don't understand what they're doing, they just is absolutely vital.
Yeah, if I can kind of build on that a couple of seconds too, if it's okay. That I think was one for us in a lot of the initial deployments. The biggest lesson that we learned was we had a bias that for what we were doing, like Jonathan's talking about. Once they understand, and I think, we've been using a framework that the VA developed for dealing with people with chronic pain issues and chronic pain management, called VEMA. Helping understand what their educating them why this is important, why what we're doing, giving them the rationale for what's happening. And then that provides the motivation and the activation that we've been looking for. And the participation at the patient level was a tremendous positive surprise.
Steve, it's Charlie again. If certainly one group that I can see will probably bring some resistance are going to be the rural hospitals, despite the fact that they're suffering, are becoming more de-skilled as they go on. If we start providing excellent care in the community, their utilization is going to go down. And so that's a major system adjustment that's going to happen. Mm-hmm.
Yeah, that's interesting that you brought that up, Charlie. And we're seeing the same dynamic here in Georgia. So I don't think this is probably just a Maine problem. And I think that's what we were trying to say. We're seeing a lot of our rural hospitals not able to, like I said, their financial models are just not even making care viable in their communities. And so these alternate models are really important. They're looking for ways to still serve their local communities and their populations.
Yeah.
And I'll make a comment to that'll get my hospital association membership cards revoked. But if we're looking to reduce the cost of healthcare, that means we actually need to reduce the amount of services. Money, it's acute care services. And sometime my grandmother was a family medicine physician in the 1930s who had her own little practice, and the docs basically ran the hospital, and it was a place where they put patients for inpatient workup, and that was it. Healthcare was at the community level in the primary care offices and the specialist offices. And over the last 50 years, we've, as a country, come to identify hospitals as being the same healthcare. And when you community about losing no longer serve a meaningful, financially viable function in that community, people think of it as losing healthcare. And so there's a huge framing shift in what we're talking about. This is healthcare. This is, in fact, more intensive monitoring. That has to happen is that we are, in fact, improving health and healthcare access, even if the consequences are reduction in access to acute care services. Move in the right direction in terms of right sizing and redefining healthcare as the health provided in your community.
Rural Nebraska, having a family member in rural Nebraska. So we were talking about the different locations and how geography might play into a part here. And I think I sort of focused on a changing model of care. I think the other side that this participant talked about is state lost different way of bring that. And any thought on how how a community goes about doing that?
I think it goes back to identifying what the community values as their healthcare priorities and focusing on and the ability. If you have a freestanding emergency department, we can reimagine hospital at home in any small community if we're able to use a combination of an agentic agent that's continuously monitoring, which is more than you're going to get on a med surg floor, and the use of alternate providers like a local and get support from your family. But that's a totally different vision of what inpatient healthcare is, and it brings a whole safety concerns to make sure we're delivering.
That it's one of the things the backbone of our whole philosophy is use data, make decisions based on data. And one of the things we're doing is we are generating an enormous amount of operational data on how services matter. So data, here are some services that would make sense to reinstate, that these are services or particular location where this is the center or nexus of some combination of problems. And so start making resource allocation decisions based solely on data. A novel concept, I understand.
That our point is not going to be an endpoint, and maybe there never will be an endpoint, but we can use the agentic system to monitor the system overall. And as Steve said, use data to really create a learning healthcare system that's going to continue to evolve based on data.
I'm sure many of us on this call have been involved in efforts to implement safety management systems and learning system structures for improvement generally, but hazard identification, mitigation, etc. In its own right. And one of the things that I have as a socio-technical undertaking is the learning structure. We have I've done work with organizations that have tried to develop patient family advisory councils. How do you integrate patients and family members into the operation of your healthcare facility? And that's always been a struggle. and care was community care was in the context of the home and in the community not all that long ago. We're attempting to return with this to the term co-production is bandied about, but this would truly be a co-productive endeavor, both through the as but also from the continuous improvement, systemic safety management. But as Jonnathan also pointed out, and Steve, I think as well, we need to understand what's really happening with this, what's happening on the ground, what are our feedback loops, do we need to improve our learning loops so that we're detecting where we're going awry or where we need to engage differently with members of community. Informed community self-determination process is incredibly robust. That's been used in Maine quite a bit over the past decade at least. So I'll stop there. We're trying to realize a dream that I think we've all tried to pursue in improving access to care. It is so broken, so fragmented right now. Two of my own family members, in the course of dying and in pain, had neurology appointments that were 2 months after they died. The individual in Nebraska brought that to mind. We have real challenges providing care to people on a timely basis. As Steve said, getting the right information to the right person at the right time. So it's an exciting prospect. I've been talking email exchanges with Nancy Levison at MIT about the system theoretic, or STAMP model. We really we have an opportunity to realize what I've found very difficult to implement in the context of hospitals with any sustainable benefit. There are some great examples to the contrary there, where systemic safety management has been implemented and sustained. But we have an opportunity to really demonstrate the integration of safety management as integral to clinical care.
Yeah, I think one other area of potential hazard and risk for any patient has to do with medication management. And Frank, do you want to speak a little bit more about the MedWell program?
Certainly. So, as mentioned before, we offer as part of the solution device-based medication management. I think, as all of us know, one of the primary reasons patients are, have admissions or readmissions is due to lack of compliance with medication. And this is something that we've been working on. HealthSaaS has been working on with AkeLex for about 5 years now. And we've seen, both as individuals with family members and then patients as part of our programs using this, how their compliance with their medication regimen has so improved by the introduction of this device. And this is something we've been doing, device-based medication management now for over a decade. It was originally designed in collaboration with Meridian Health, now Hackensack Meridian post-merger. And, it's in the current MedWell device. This is a Gen 2 device. So the Gen 1 device was much smaller. And what we found real quickly is it just did not accommodate enough oral medications. So this thing, my wife affectionately calls it Mr. Beepy. In addition to the LED indicator, it makes a beeping sound. We live in about a 2,000 square foot ranch home. My office is in the back corner. Her office is in the other corner of the house. She can hear it across the house. It's really difficult to miss your meds when you have one of these. It uses industry standard blister packs. So we're not reinventing the world here. So we have a pharmacy partner that sorts, fills, seals, and delivers a blister pack to a patient's home. All they do is rip off a strip. So this is a daily device, morning, afternoon, evening, and night. The schedule is set in our portal. So we do the med sorting and the scheduling in the portal. That schedule is sent to the MedWell device, and it's absorbed by the firmware, so it knows when to flash and beep. I think Steve Steve and Charlie both as clinicians, and Steve having used this both personally and with clients, could speak to this a little better and where we're going with therapeutic optimization relative to medication adherence.
Just to underscore the importance of what you just shared, Frank, one of the first cases I looked into when we moved back to Maine was a death involving a woman who had mistook a dosage of 0.2 milligram pills for taking 2, and she ended up taking an excessive amount of an anticoagulant, was dizzy, fainted, hit her head on her wood stove, and died. I mean, medication stuff is serious. It's a serious concern in any context, but in rural areas where people have so few people to turn to for guidance and difficult accessing professional guidance, including pharmacy, it's really important.
As it just, y'all have really, we're at the end of our time, so I know people will probably have to stop, start dropping at this point. But wow, I just want to say from my perspective, thank you all for coming to this session and sharing. There's just so much that you've kind of triggered, and this was exactly why we were hoping that we saved you guys for last and for this group, because I knew it was going to lead us to be thinking about new ways that we're going to have to, new challenges that we're going to face in the safety realm, right? And we're projecting safety beyond, walls of a clinic or walls of a hospital into potentially into patient safety into the home. And what you're talking about is how many more lives can be saved. Jeff, you're kind of bringing that to the forefront if we had some of these systems in place, right? And this is exactly the kind of conversation, that we definitely wanted to have. So thank you all so much for joining today. Thank you for participating. I know we'll be talking more with you all as we look at opportunities to continue to improve the safety of the system in which this care is expanded. Anybody have any last comment or thoughts they want to add before we close?
I would like, if you don't mind, if we could take 1 to 2 more minutes, because one of the things that we did not discuss here, and it ties direct to patient safety, is the ontological AI that is really the core of what we're doing.
Yeah,
here.
please. Yeah, go ahead, Frank. So,
Steve, if you want to talk about how the ontological AI plays directly into patient safety, that'd be great.
Yeah. So obviously there's a lot of debate going on about the utility and safety of AI and health systems. And obviously I think a lot of what people are thinking about is large language models specifically. So although we use large language models in certain aspects of the operation, the core of our system is an ontological knowledge system. So, one of the challenges with large language models is they're semantic and rhetorical tools. So they're looking at the usage of language terms without necessarily behind. So they're looking at utilization, which can be, very interesting, effective. But it's also a lot like social media. It can sound very, very convincing, but not necessarily be based in reality. So by having an ontological system, which is foundationally everything the knowledge system knows is structured into these representations, neural symbolic representations of disease processes, conditions, therapies, and so on. So the system can't really get confused or go out of the bounds of that in runtime. So it's limited to what is known. And, in our experience, one of the things that the kinds of things that make people trust these systems more is how do we get authority? How do we provide authority for these systems so that when people look at it, they have a high degree of trust? And the way we've approached it is to provide total transparency. So the system, a user can actually, if they choose to do so, can actually pursue where the information came from and the exact sequence of events in an unbroken chain of evidence from the source, reference materials, to how it was being employed and how it's being weighted by the AI system in runtime. So we provide that complete transparency, which we think is very, very important. So users can query that at any time. So, you can use generative AI to help communicate information with the patients and clinicians and make the information more succinct and flow better. But at the end of the day, the authority of the system is always linked to this ontological structure. Now, the ontological structure is fixed in runtime. It learns offline. So we don't allow the system to learn in runtime. We allow it to identify potential areas for learning that get presented to the curation layer. And then that, once it's curated, can be fed back into the runtime environment. So it is a learning system. It is a knowledge, a learning AI system, but it has a number of components. And in runtime, it operates as a very sophisticated, deterministic, frame-based expert system. So with very high authority.
Thanks, Steve.
Yeah, that's very helpful, and it kind of grounds us in also some of the questions that we started off the week with around the safety of AI, right? And the understanding, and a lot of that is the transparency, how the system is being trained, how it works, how it's being monitored. Also, your description of how it learns is really interesting as well. So you guys have really brought a lot to the conversation. I really appreciate everyone.